Good evening, everyone, and namaskar for the today's session, New Year updates in Medical Oncology 2025. And I would like to invite Dr. Ajay Sharma, sir, and he is a medical oncology founder and director, AS Lifeline Cancer Care Hospital, Rohini, to give his opening remarks. So it's over to you, sir.
Thank you, and very good evening to all of you. So, again, I'll say a small and very interactive session we'll be having about the newer updates in medical oncology, and especially we will be talking about the lung cancer, the targets, targeted therapies, the new biomarkers, and how to diagnose. So, there are three speakers, I'll say. And first of all, the speaker would be Dr. Wani. She would be speaking about how to proceed lung biopsy and principles of molecular and biomarker analysis. And it would be followed by Dr. Nishant, that is overview of lung cancer. And then would be Dr. Ashish Upadhyay, the real world evidence, osimertinib in the treatment of metastatic EGFR non-small cell lung cancer. And the last topic would be covered by me. It would be the targeted therapies, the evidence-based review in the advanced metastatic EGFR mutated non-small cell lung cancers. And then again, the closing remarks would be done by me. So I would like to request Dr. Ruhani. Are you there?
Yes, sir. Good evening, sir.
So good evening, Dr. Ruhani. I think you can proceed and you can start your topic.
Okay, sir. Thank you for introducing me. My topic is molecular biomarker testing in lung cancer. The content will be lung cancer in India, biomarkers testing in non-small cell lung cancer, evaluation of biomarker test in non-small cell lung cancer, past and current, and key takeaways. The burden of lung cancer in India, Globocare 2020, according to which number of new cases in 2020, both sexes and all ages, lung cancer is 5.5%, and number of new cases in 2020, male all ages is 8%. Nearly 50% of patients with
Kindly
advanced.
share your PPT slide.
I think there is some problem in sharing the PPT slide. Can somebody of you can do the work for her?
Yeah, sure, I will.
Thank you.
Is it visible, ma'am?
Yeah, thank you. So, as I have discussed, the burden of lung cancer in India, Globocare 2020, lung cancer among number of new cases in 2020, both sexes, all ages is 5.5%. And number of new cases in 2020, male, all ages is 8%. Next slide, please. Nearly 50% of patients with advanced non-squamous non-small cell lung cancer have a driven mutation targetable with a FDA-approved agent on or on clinical trial are ALK, EGFR sensitizing 17%, KRAS 25%, unknown oncogenic driven detected is 31%, EGFR other is 4%, MET is 3%, more than one mutation 3%, HER2 2%, ROS1 2%, BRAF 2%, RET 2%, NTRK1 1%, PIK3CA 1%, MEK1 nearly less than 1%. Next is the importance of biomarkers testing in non-small cell lung cancer. Studies have shown that patients with identified actionable mutation who received appropriate targeted therapy have improved outcomes. As we can see in the diagram, the blue line is targeted therapy and red line is non-targeted therapy. So we have received good results in targeted therapy. Next, guidelines recommended routine biomarker testing to guide treatment decisions in advanced non-small cell lung cancer. Biomarkers include EGFR mutation, ALK rearrangements, ROS1 rearrangements, BRAF mutations, MET exon 14 skipping, RET gene fusions, NTRK gene fusions, KRAS mutation, PDL1 expression. Next slide. Method of tissue testing in non-small cell lung cancer. Tissue testing method are DNA sequencing, NGS, PCR, RNA sequencing panel, and IHC FISH. DNA sequencing, NGS, PCR detection, detects insertion, point mutation, deletions, and detects aberrations in EGFR, KRAS, BRAF, HER2, MET, MET, single gene or full NGS panel. In RNA sequencing panel, detects fusion abnormalities, more sensitive for ALK, ROS1, RET, NTRK, IHC, and FISH. FISH detects ALK, ROS1, highly specialized, can faster. IHC detects ALK, ROS1, easy test, fast, but not reliable or sensitive enough to guide treatment. Detects PDL1. Now, next, evolution of biomarker test in non-small cell lung cancer, past and current. So, there is tissue journey biopsy to analysis. Preliminary diagnosis is there, biopsy method and specimen processing, morphologic assessment, extraction and analysis. So, preliminary diagnosis will do by tissue, cytology, and liquid. In tissue, it includes resection, excision, small tissue biopsy. After that, FFPE block is made. Then, by histology and cytology, we'll see parallel diagnostics. And through that, we can assess methods by PCR, cancer gene panels, MSI, WES, WGS, targeted mutations. And RNA will be assessed by RT-qPCR, gene expression panels, RNA sequencing, and protein will be analyzed by proteomics, FACS, and data analysis. Similarly, through cytology also we'll get this DNA, RNA, and protein through fine needle aspiration, exfoliative cytology from urine, ascitic fluid, pleural fluid, sputum, cerebrospinal fluid, residual supernant. And similarly with liquid biopsies such as blood and cyst fluid, we all take and have a key personnel are surgeons, pathologists, allied health professionals, clinical informaticians, patients, and key personnel for morphology extraction and analysis are pathologists, laboratory staff, clinical informaticians, and bioinformaticians. Next, biopsy established diagnosis, determine histologic subtype. Biomarker testing is first done by histologic subtyping, squamous or non-squamous. For biomarker testing, primary tumors and metastatic lesions equally suitable. Bone biopsy can be suboptimal due to decalcification, degradation of DNA. Then liquid biopsy, cell-free DNA in plasma are another option. Test for EGFR, ALK, ROS1, BRAF V600E, NTRK, RET, MET-X14 in all squamous non-small cell lung cancer. Use broad NGS testing to detect most mutation using least amount of tissue. For squamous and non-small cell lung cancer, consider testing in young, never light smoker, or if biopsy specimen is of mixed histology. Test for PD-L1 expression in all non-small cell lung cancer. Completion of testing within 10 to 14 working days of biopsy recommended. Next, ctDNA testing has been potential to be applied across all stages of non-small cell lung cancer and throughout the treatment pathway. First is diagnosis and treatment selection. Second is monitoring prognosis, response to treatment and progression or relapse of disease. Third is ctDNA testing overcome some major challenges associated with tissue testing. Then heterogeneity and tumor changes over time. ctDNA testing may never replace tissue biopsy entirely, but could have a complementary role to support treatment selection in patients with non-small cell lung cancer. Next. ctDNA may be used to detect MRD after surgery in resectable non-small cell lung cancer. ctDNA testing could identify people at risk of relapse and allow for appropriate intervention. Presence of MRD may be used to predict disease recurrence. Currently, MRD cannot be identified using traditional diagnostic methods. As detected on ctDNA in plasma indicates the presence of residual tumor tissue. It can be used to measure MRD. In Tracker X study, ctDNA profiling was able to confirm MRD negativity and detect MRD in patients who relapsed before their disease was picked up by standard imaging. Next is comparison of tissue versus liquid biopsy testing. There are similarities and differences between tumor tissue and liquid biopsy testing for molecular alterations. First is tumor tissue, second is liquid biopsy. And topic is sample acquisition. In tumor tissue, invasive surgical procedure to obtain tumor tissue. In liquid biopsy, it is simple blood draw, generally 10 ml whole blood. Repeat sampling. In tumor tissue, serial testing challenging with variable biopsy and patent risk. In liquid biopsy, it is minimally invasive procedure, allowing for easy serial testing throughout the course of therapy. In biology, tumor tissue is correlation with histology and cellular phenotype possible. But in liquid biopsy, direct correlation with between ctDNA results with histology or cell type not possible. More reflective to tumor genomic landscapes. Sensitivity of assay required in tumor tissue is lower tumor cell content acceptable with sensitive technique around 1 to 10%. In liquid biopsy, very sensitive method required as ctDNA may comprise less than 0.1% of ctDNA. In analytical standardization, tumor tissue uses existing validated tissue processing and handling procedures. In liquid biopsy include standards of analytic performance, characteristics of cfDNA, ctDNA, have not been established. No guidelines exist regarding the recommended performance characteristics of liquid biopsies. Evidence of clinical utility in tumor tissue, substantial evidence for initial targeting treatment, selection and subsequent treatment after targeted treatment failure in advanced non-small cell lung cancer. In liquid biopsy, it's less but increased evidence of initial targeted treatment, selection and subsequent treatment after targeted treatment failure in advanced non-small cell lung cancer. Then a multiple gene involved in non-small cell lung cancer, single gene reflect testing or multiple gene testing by NGS. So this is the model diagram. Now advantages of NGS. NGS has a number of advantages over single gene tests, as the number of clinically actionable biomarker has increased the ability to evaluate all known molecular alteration in single test has given NGS a major advantage. Pros of using NGS versus single gene test are detect a broad range of molecular alteration in the single sample, may identify new markers that could offer additional treatment option for a patient and or provide information to help with development of new and more effective treatments. Cons of using NGS versus single gene tests are high complexity of workflow that requires experienced personnel and advancement in the field of NGS are evolving rapidly. Patients and the clinical community must receive sufficient education in this area. Next, techniques and molecular landscape in non-small cell lung cancer. EGFR mutation in lung adenocarcinoma. Next, EGF mutation in lung cancer. Sample types used for EGFR mutation testing are FFPE section, fresh frozen or alcohol fixed specimen can be used for PCR-based assay. Cytology samples are also suitable. Cell blocks are preferred over smears. Next. Factor determining the choice of EGFR mutation testing method. Sample type, high tumor content, low tumor content. In high tumor content, most testing methods are suitable. Low tumor content, sensitive testing method required. Relevant expertise, yes. Recommended using method that the laboratory is expert at using. No, consider using an external provider or commercially available EGFR mutation test kits. Mutations, known targeted or screening method suitable. Screening method should be combined with sensitive targeted method in case of mutant DNA level is low. All mutation use screening methods in combination with tumor enrichment or a sensitive targeted method in case mutant DNA level is low. A suitable testing platform must be chosen, weighing all the factors involved. EGFR-M testing in early lung cancer. Advantages of NGS over PCR. One, study showed that 48.6% of EGFR X20 in mutations identified via NGS are missed by PCR. Out of 17 most common EGFR X20 mutations variant, only 4 can be identified via PCR.
I'm sorry for interrupt you. Which page you are reading?
I am on 23.
Okay.
Yeah. Next is ALK rearrangement in non-small cell lung cancer, which is on page number 24, now 25. In most cases, ALK IHC is 93 to 100% sensitive and specific compared to fish. So false positivity rate of 0.1% with fish, IHC is less expensive, hence more widely adopted. Next, ROS1 rearrangement in non-small cell lung cancer. Algorithm for predictive genetic testing ROS1 in advanced non-small cell lung cancer routine practice is NSCLC, adenocarcinoma or non-squamous and non-smoker with squamous histology have three parts: EGFR, ROS1, ALK. In ROS1, there is ROS1 IHC and ROS1 FISH. In ROS1 IHC, there is ROS1 S1 plus, ROS1 negative. And ROS1 positive is reconfirmation by a second method, example FISH or another molecular assay. In ROS1 FISH, there is ROS1 positive and ROS1 negative. ROS1 positive consider reconfirmation by a second method by IHC or another molecular assay. Detection of elevation of ROS1 protein levels by immunohistochemistry may provide cost-effective screening prior to confirmatory FISH testing. Next, KRAS G12C mutation in non-small cell lung cancer. Encoded protein is RAS sends activating signals to the number of cellular pathway involved in cell proliferation and survival, in which mutations are KRAS mutation are mutually exclusive with EGFR and ALK mutation and account for nearly 30% of lung adenocarcinomas. The most common of these arise in codons 12 and 13 with the G12C variant, found in 13% of patients with lung adenocarcinoma, predicting poor prognosis versus wild-type KRAS. Method of detection is single gene KRAS G12C testing is not currently recommended and should only be performed as a part of multi-gene NGS panel. Targeted therapies. Identification of targeted therapies for patient with KRAS mutation has been hindered by the protein structure biology, which has no binding pockets large enough for therapeutic agents. Acquired resistant to therapy has been observed, although specific resistant mechanisms are not well understood. Next page. BRAF mutation in non-small cell lung cancer. In this encoded protein, the RAF kinase is involved in regulating cell proliferation and survival of facilitating signal transmission between the cell surface and the nucleus. Mutation is the BRAF V600E mutation, present in more than 50% of BRAF mutation cases and is through to be more prevalent in smokers. Non-V600E mutations such as V600K, G466V, and G469A are less prevalent and occur in nearly 17% of patients with BRAF mutation. Overall, BRAF mutation occur in 1 to 5% of patients with non-small cell lung cancer, most commonly adenocarcinoma. Next. c-MET receptor, tyrosine kinase, and MET exon 14 skipping mutation in non-small cell lung cancer. Normal role in embryogenesis and wound healing. In cancer, majority of MET-X14 skipping mutation can be detected with DNA NGS, but increased sensitivity with RNA NGS. Method of MET-X14 mutation detection. IHC not recommended, FISH not recommended, PCR, DNA design dependent, RNA technical consideration, NGS, DNA design dependent, potentially detects many mutation, RNA most sensitive. RET receptor tyrosine kinase and RET fusion in non-small cell lung cancer. Majority of RET fusion can be detected by DNA NGS, but increased sensitivity with RNA NGS. Method for RET fusion detection. There are four methods: IHC, DNA NGS, and RNA NGS. Majority of RET fusion can be detected with DNA NGS, but increased sensitivity with RNA NGS. Testing for anti-RK fusions. Options are IHC, RNA or DNA, NGS, FISH, RT-PCR, reflexing to NGS versus IHC, reasonable for non-small cell lung cancer due to low prevalence of anti-RK fusions. Methods for anti-RK, TRK fusion detection. Advantages are NGS potential for NGS advantages are potential for multiplex testing, less depletion of tissue, fusion partner and position are defined. RNA NGS more sensitive. Disadvantage. HER2 mutation in non-small cell lung cancer is in non-small cell lung cancer, HER2 mutation and amplification must be identified using an NGS DNA panel. IHC used to assess HER2 overexpression seen in 59% of non-small cell lung cancer cases is 2 to 3 up to 30%. Next page. Next. 2022 treatment paradigm for molecular biomarker positive advanced non-small cell lung cancer is as shown. Follow treatment options for adenocarcinoma or squamous cell carcinoma without actionable biomarkers, i.e. chemotherapy and immunotherapy. For EGFR, ALK, ROS1, BRAF, V600E, NTRK, RET, MET-EX14 skipping, and KRAS, G12C. Next page is PDL1 overexpression in non-small cell lung cancer. PDL1 antibody clones, IHC platform and scoring system in lung cancer is platform is DACO, VETANA. Next, PDL1 testing, different antibody used are a different scoring system is adopted depending on the antibody used to detect PDL1. Biomarker for immunotherapy in non-small cell lung cancer, a controversial topic. PDL1 sole current biomarker able to guide immunotherapy. TMB former marker for response not currently used. MSI high MMR not used or relevant in lung cancer. LAG3 possibly related to resistance to immunotherapy being studied. Next, conclusion. Biomarker testing in non-small cell lung cancer has evolved from single gene to multiplex testing. Multidisciplinary meetings help in better understanding of sample and test requirement. Samples should contain adequate tumor content, at least 10%, to prevent delay in processing. Ideal TAT is 2 weeks, 10 working days. High throughput platforms such as NGS can be used to screen several genes at a time to provide result within the estimated TAT. Oncogenic targets and testing methodologies. These are EGFR mutations, PCR NGS, BRAF mutation, PCR NGS IHC, KRAS mutations is PCR NGS, and so on. Okay, so this is the end of our discussion from my side. Thank you.
I think, thank you, Dr. Rohani, for your wonderful presentation. So, in continuity with our webinar, now I would like to invite Dr. Nishant. So he will be speaking. He will be covering the like overview of the lung cancer. So, Dr. Nishant, please.
Good evening, sir.
Good evening. Good evening.
Good evening to all my respected sir and our webinar team. I am Dr. Nishant Bhaskar, RMO at AS Lifeline Cancer Care, Darbhanga. I am going to represent a topic which is overview of lung cancer. So I would like to start. The burden of lung cancer in India, Global 2020, in which we see the number of new cases in 2020, which include both sexes and all ages, in which there is breast cancer, which is 13.5%, lip and oral cavity, which is 10.3%, cervix and uterine cavity cancer, which is 9.4%, and lung cancer, which is 5.5%, and colorectal is 4.9%, and other cancer which is 56.5%. And we see the data in 2020, in which lip oral cancer are represented at 16.2%, and lung cancer 8%, stomach cancer 6.3%, and colorectal 6.3, and esophageal 6.2%, and other cancer involve 57%. This is the second most common cause in lungs, which involve our lung cancer. We see the data over here, in which lung cancer has a number which is 72,510. And the first number of cases is breast cancer, which is large in the number. Optimal staging is required to decide best treatment option in early lung cancer. We see here the T component like TNM classification, in which we see tumor size, lymph node involvement, and metastasis, in which we see the data T2, which involve size more than 5 centimeter, and T3 involve more than 7 centimeter. But in its addition, T4 involves more than 7 centimeter, and N1 classification is 3A and 3B, in which we see there is a metastatic are seen and sometimes not seen. Investigative tool for staging, which involve bronchoscopy, CCT chest, PET-CT, E-bus use, and mediastinal scopy, MRI brain. CCT versus PET-CT for staging in stage 3 NSCLC, in which lymph node size is more than 10 mm along short axis and predictor of malignancy. CT scan alone has a limited role due to low sensitivity, which is 55%, and low specificity, which is 81%. It may help in selecting appropriate procedure, tissue sampling by providing the images. Addition of PET-2 CT involve the overall sensitivity of 80 to 90% and specificity of 85 to 95%. Risk factor for occult N2, which is not always detected by imaging. We see the percentage occult N2 metastatic for a clinical tumor size and located tumor, peripherally located tumors and its p-value. We see there is tumor size which is 0 to 2.0 centimeter and a centrally located tumor which is 14.3 and peripherally located 2.9. And like all tumor size, we see the data here, which is 21.6 and peripherally 2.9 and p-value which is less than 0.0001. And in which we see the central tumors and the size of tumor and higher SUV on PET. Mediastinal staging, in which a less invasive EBUS and EUS biopsy. Invasive is mediastinoscopy and conventional VAMLA and TEMLA and VATS. Mediastinal staging involves recommended techniques like EBUS and EUS. If clinical suspicion of N2 involve remain high even after a negative EBUS or EUS, then surgical staging with mediastinoscopy is recommended. When is invasive mediastinal staging indicated? It is indicated when centrally located tumor size which is more than 3 centimeter and extensive infiltration of mediastinum with no evidence of extrathoracic disease like positive N1, bulky N2 on CT, no need for invasive confirmation. And in discrete N2, yes, it is regardless of PET-CT result. And in normal mediastinal on CT, but positive on PET and negative PET involves no determination. Mediastinal staging algorithm protocol, in which a PET-CT with intrathoracic lung cancer with or without enlarged lymph node. If it is positive, then non-mass or non-bulky lymph node sample is taken and then there is tissue confirmation in which we see the mediastinal lymph node is positive or negative. If it is negative, then multidisciplinar evolution of surgical staging is involved, and it have two subtypes like mediastinal, it is negative or otherwise it is positive. If positive, then multimodality treatment will be required. And in other side, we can see if mediastinal lymph node is negative, then we can go with a CN1 or CN0 and a high probability of unforeseen of N2 disease after negative PET-CT. Thereafter, there is tissue confirmation with EBUS or EUS, and it also indicate two subtype, either it is positive or negative. If it is positive, then multimodality treatment is recommended, and if it is negative, then surgical or radical therapy is recommended. Lymph node station accessibility. Procedures involve like EBUS, use cervical mediastinoscopy, extended mediastinoscopy, left VATS, right VATS, VAMLA and TAMLA. We see data over here like 2R, 2L involvement and positive of EBUS and EUs. Non-invasive and invasive staging modalities. Modalities are CT scan, PET scan, EBUS, use, MED, VAM, EBUS plus use, EBUS plus use, and mediastinal and VATS. Sensitivity percentage data we see here, CT scan involve 55% and the highest sensitivity is of VATS, which is 99%. And Upper mediastinal stations like CT scan shows present, and lower mediastinal stations like 8 or 9 in which EBUS are negative, and in AP zone also EBUS are negative. So we see the sensitivity is largest of VET and less sensitivity is shown with CT scan. Evolution of therapy in lung cancer. NSCLC was once considered a single disease until distinct subtype characteristics identified. NSCLC subtype characteristics are clinically relevant for treatment planning from diagnosis. A traditional view in which lung cancer and NSCLC and other is SCLC, and histological breakdown, example SQ, NSQ, large cell or adenocarcinoma. So we see the tumor mutational burden, which is more than 10 mutations and less than or equal to 10 mutations, in which PD-L1 expression levels are expressed by the presentation of the advances in management of NSCLC has improved survival. The background is lung cancer is made up of distinct subtypes, including non-small cell lung cancer and small cell lung cancer. All through overall mortality from lung cancer has been declining in the United States. Little is known about mortality trends according to cancer subtype at the population level because death certificate do not record subtype information. Methods involves using data from surveillance, epidemiology, and in the result areas. We assessed lung cancer mortality and linked death from lung cancer to incident cases is SEER cancer registries. This allow us to evaluate population level mortality traits attributed to specific subtypes in which incidence based mortality is used. And we also evaluated lung cancer incident and survival according to cancer subtype, sex, calendar year. Joint point software was used to access changes in incident and trends in incident-based mortality. The result shows the mortality from NSCLC decreased even faster than the incidence of this subtype, and this decrease was associated with substantial improvement in survival over time that correspond to timing of approval of targeted therapy. Among men, incidence-based mortality from NSCLC decreased to 6.3 annually from 2013 through 2016, whereas the incidence decreased 3.1% annually from 2008 through 2016. Corresponding, the result is lung cancer specific survival improved from 26% among with men and with NSCLC, and that was diagnosed in 2001 to 35% among those in whom it was diagnosed in 2014. This improvement in survival was found across all races and ethnic groups. Similar patterns were found among women with NSCLC. In contrast with mortality from SCLC, declined almost entirely as a result of declining incidence with no improvement in survival. This result correlates with limited treatment advance from SCLC in time frame that we examined. The conclusion is the reduction in incidence along with treatment advances and particularly approvals for and use of targeted therapy. It is likely to explain the reduction in mortality observed during this period. So we see here advanced treatment of NSCLC in early and late stage targeted, which is with targeted and immunotherapy. We see see here a significant increase in approval of both targeted as well as immunotherapy in NSCLC. Chemotherapy with bevacizumab of non-squamous NSCLC was approved in October 2006. Platinum with pre-metastasis of non-squamous was approved in 2009. And in 2020, atezolizumab for NSCLC, which is equality or more than 50% of with PD and L1 expression, and ipilimumab and nivolumab for NSCLC with 1% or equal to 1% with PD-L1 expression. Molecular targets in NSCLC. The molecular profiling of NSCLC has identified many alterations and their subtype. All patients with NSCLC should undergo molecular profiling to identify targetable alteration. Molecular complexity of adenocarcinoma, we see data over here in the form of graph and with colors. There are now 7 molecular alteration with FDA approved targeted therapy, which is EGFR, ALK, ROS1, BRAF, P600E, anti-RK, MET exon 14, RET. So this increases the need for molecular testing in NSCLC, and molecular testing should be a standard of care in NSCLC. Current guideline on neoadjuvant and adjuvant chemotherapy depend on disease stage and finding during surgery. Pathology stage, in stage 1A, in which N is 0, there is no lymph node involvement. Recommended chemotherapy treatment is observation. No proven benefit of neoadjuvant or adjuvant chemotherapy. In stage 1B or 1A, multidisciplinary team discuss observation versus adjuvant chemotherapy for higher risk patients, and no proven benefit of neoadjuvant chemotherapy. In stage 2, 2B, and 1 lymph node involved, the recommendation of chemotherapy treatment is adjuvant chemotherapy, and no proven benefit of neoadjuvant chemotherapy. And in stage 3A and 3B, in which N1 and N2 lymph node is involved, the chemotherapy treatment is a neoadjuvant chemotherapy or adjuvant chemotherapy or sequential chemotherapy plus radiotherapy. Finding at surgery and surgical resection margin affect adjuvant treatment decisions. Resection margin as well as pathological stage affect adjuvant treatment decisions, like finding at survey in stage 1A and 2A, there is complete resection. We see here there is observation chemotherapy for high risk patient, like who is in stage 1B or 2A, and incomplete resection R1 or R2. Resection is preferred for radiotherapy, and chemotherapy may be present or may not be present for stage 1B and 2A. And in stage 2B, in which annual lymph node is involved, there is chemotherapy and resection plus chemotherapy or CRT, R1 sequential or concurrent, R2 concurrent. And in stage 3A and 3B, in which N1 and N2 lymph node is involved, chemotherapy, sequential chemotherapy plus radiotherapy, and in incomplete resection, R1 CRT sequential or concurrent, or R2 CRT concurrent. After initial treatment, more than half of patients with resectable NSCLC experience recurrence with 5 years. Surgery which present with chemotherapy or radiotherapy, we see 40 to 50% remain cancer free. and 50 to 60% having reoccurrence who have local and distant reoccurrence. So we see overall outcome still need to be improved for patient with resectable NSCLs. Here is the ISMO guideline recommended that adjuvant chemotherapy can be considered in patients with resected stage 1B disease and primary tumor, which is more than 4 centimeter in size due to clear evidence of benefit. So we see the data over here. In stage 1B and tumor diameter, which is less than 4 centimeter, the percentage and the time here. And in stage 1B and a tumor diameter, which is more than or equal to 4 centimeter, we see the percentage and time. So observation is 54 and chemotherapy is 66. So however, since these guidelines were published, stage 1B tumor more than 4 centimeter have been reclassified as stage 2 in 8th edition of TNM staging 2018. Therefore, adjuvant chemotherapy is now the standard of care for these patients. Adjuvant chemotherapy may remain an option for patients with stage 1B disease and in 8th edition of TNM staging who are high risk due to factor other than tumor size. Less meta-analysis, OS benefit from post-operative cisplatin in early stage NSCLC. Pooled analysis of 5 trials evaluating adjuvant cisplatin-based chemotherapy. Cisplatin vinorelbine, most commonly used agent, only combination shown to prolong OS. Chemotherapy led to improved OS. So we see the OS percentage and year from randomization control. The blue in color demonstrate the chemotherapy and red represent the no chemotherapy data. So how well does neoadjuvant induction chemo work? So about the same, it works about the same as adjuvant. And for stage 1B and 3A, neoadjuvant chemo, HR which is 0.87, and adjuvant chemotherapy, in which HR is 0.89. So we see the data over here, post-operative chemotherapy and its control. Like a country in France, 1919, the pre-operative chemotherapy, which is 8 by 18 in number of cases, and controlled is also 8 by 18, and the variance is 3 to 97. So we see the data over here among the different countries. Improving survival in resected NSCLC. Targeted therapy is now moving to early stages. The Adhura trial is implemented, in which improved DFS seen with osimertinib in a resected EGFR NSCLC. So patient with completely resected stage 1B, 2 or 3A EGFRM mutation, osimertinib versus placebo for 3-year or recurrence. So 80% is reduction in the risk of disease, recurrence of death with osimertinib. So with introduction of EGFR TKIs and DFS, it is improved from 44% in placebo to 90% in EGFR TKI arm at 24 months. So it is now also possible to further improve survival in completely resectable stage 1, 2, and 3 NSCLC. Atezolizumab showed an improvement in DFS as well as adjuvant set. So we see the data over here, month and the survival in disease survival in percentage. So atezolizumab showed an improvement in survival in adjuvant setting in patients who had PDL 1 or less than 1%. Such therapy will help improve survival rate in NSCLs. Lung cancer radiation in 2022. Advanced technologies have led to suffer treatment. Intensity modulated radiation therapy, IMAT, has been shown to improve the survival for patients with stage 3 NSCLC and with tumor size T3 and T4 tumors. Reduce dose to heart with lower rates of grade more than 3 or equal to 3 pneumonitis. Increasing dose to heart associated with higher risk of death in stage 3 NSCLC. So the treatment planning is non-modulated beams, conventional, in which beam intensity, a tumor cord, and IMART is introduced. Semantics for radiation. What is relevant to pulmonologists? Important to differentiate between a stereotactic body radiation therapy versus conventional fractionated external beam radiation, which for stage 3 NSCLC is typically IMAR technique. SBRT is a high dose per fraction, typically 8 to 20 radian per fraction and 1 to 5 fraction with 3D target localization. SBRT is used in early stage lung cancer, but due to concern for toxicity, not standardly used for large tumor like more than 5 centimeter and with and 2 nodes. 4D CT planning allows for margin around tumor to be minimized. Image guided radiation therapy IGRT ensure accurate target coverage for every treatment while reducing margin needed to cover tumor. Adaptive radiation, creating a new radiation plan after tumor target volumes have reduced in size, allowed for normal tissue sparing, and the end result in which a smaller target volume with lower doses to normal tissue included lung, esophagus, and heart. So contemporary art radiotherapy techniques in stage 3 NSCLC.
It's 7 o'clock, so I think if you can wind up a little faster.
Yes, sir. So we see the targeted therapies are improving outcome in advanced NSCLC. We see data over here. Other emerging molecular target in NSCLC and immunotherapy in NSCLC, in which immunocheckpoint inhibitors using body-own immune cells to fight against the cancer, in which PD-1 and PDLA blockades are involved, and T-cell activation permitted by antibody blockade of PD-1 or PDL1. So checkpoint inhibitor has improved survival in advanced NSCLC. The keynote showed the improved survival in patients with pembrolizumab compared to chemotherapy with PD-L1 TPS, which is more than or equal to 50%. Almost 32% patients are alive at 5 years with the use of IO in metastatic NSCLs. So key takeaway message is the management landscape is fast changing in NSCLC. Newer therapies have a huge potential to improve survival, especially when detected in early stage. The OS has improved across various subtypes with molecular alteration. The case of oral pills over infusion in case of targeted drugs is an added or advantage, and pulmonologists will play a huge role in early diagnosis. Hence, it is crucial to involve them in NSCLC tumor boards. So, thank you.
So thank you, Dr. Nishant, for the extensive learning about the overview of the lung cancer. So I'm sorry I have to cut you short for the paucity of the time because there is a slot allotted to each one of us. So to continue with our further discussion, here now I request Dr. Ashish Upadhyay to speak about his topic, which is real world evidence osimertinib in the treatment in metastatic EGFR NSCLC. So, Dr. Ashish Upadhyay, please.
Thank you, sir. Thank you very much. Good evening, everyone. First of all, I would like to thank Ajay sir and AstraZeneca for inviting me. So I'll share my slides first. Are my slides visible?
Yes,
Yes,
sir.
Dr.
Make it
Ashish,
full screen,
they are
please.
visible. Yes,
Yeah, it's visible.
Okay. Are they moving?
Yes,
yes,
sir.
they are moving
Okay.
to.
Thank you. So I'll be talking about the real world evidence of osimertinib as first line therapy in metastatic and advanced non-small cell lung cancer. So to start with the famous FLORA study, we all know the double-blind study, in which locally advanced or metastatic non-small cell lung cancer patients with age 18 and above, performance status of 0, 1 with exon 19 and 21 deletions and without any prior systemic therapy or EGFR ticker, with stable CNS patients, brain mets patients, were allowed. The stratification factors were mutation status and race. The patients were randomized 1:1 is to into osimertinib versus the comparative TKI, that is gefitinib or erlotinib. And the response assessment was every 6 weekly until progressive disease was confirmed. Crossover was allowed. The primary endpoint was PFS and the secondary endpoint was overall survival and objective response. So baseline characteristics were well balanced across the trial. Median age group was 64 in both the groups. Around 20% of brain mets patients were included in both the groups. Again, if you talk about exon 19 and 21 proportion, it was almost similar, 63 versus 37%. So if you see the PFS, the forest plot of the PFS, there was a drastic improvement from 10.2 to 18.9 months with a hazard ratio of 0.46, and almost all the subsets got benefited with osimertinib. Same was the case with median overall survival also. Median OS increased from 31.8 months to 38.6 months with a hazard ratio of 0.80. If you talk about the CNS analysis, then we can see for CNS PFS, we can see the early separation of the curve, and the curve is well separated even after 20 months. If you talk about the hazard ratio, that is 0.48. So there is staggering 52% reduction in the risk of CNS progression with osimertinib. Another, if you see the cumulative CNS incidence, it was more with comparative TKI as compared with osimertinib at 6 months, and at 12 months, we can see the CNS events with osimertinib was much less as compared to the comparative TKI. Safety profile, we all know it's a very well tolerated regimen. Mostly tolerable adverse events in the form of rash and diarrhea is what we feel. So, and the safety profile was mostly similar as of osimertinib as compared to the comparator TKI. So, Flora gave us improvement in PFI by osimertinib as compared to the comparative TTI with a hazard ratio of 0.46. There was also improvement in the duration of response, which increased from 8.5 months to 17.2 months. Osimertinib also demonstrated improvement in overall survival as compared to comparator TKI with a hazard ratio of 0.80. And there was also an improvement in CNS PFS, and safety profile was also similar to other TKI. So the answer we have that Flora gave us excellent OS and PFS. The median age group we all know was 64. Patient from 26 to 85 years of age were taken, and it also gave us CNS result. That was there was improvement in CNS PFS as well. So the question which was not answered, will it be replicated in real world? Will it be tolerated by the elderly population? These are the two basic questions. So for that, we should understand what is the importance of real world evidence. So randomized control trial, as we all know, it has a pre-specified criteria done on an homogeneous patients. So its acceptance is definitely high. But if you talk about the representativeness, then real world evidence gives the more representative data, because it has almost all different subgroups or rarest of the rarest patients, which we miss out in randomized control trial. If you talk about the validity is more with randomized control trial, but again, the applicability is more with real world evidence. So that is why even after randomized control trial, real world evidence is very important. So these are the real world evidences which we're talking about: flower study, hot 202, and then few other studies also, one by one. So in a nutshell, the studies basically, first the flower study, which took 126 patients. It's a real world prospective observational study enrolling patients referred to 9 Italian oncology centers. OSIFEC, another study which took 538 patients from Japan. Mycon was another study from USA and Germany, a Spanish study, and then we have another study for elderly population. So few terminologies that are important in real world evidence, like time to treatment discontinuation. It is defined as the date of starting of medicine to either date of treatment discontinuation or death. Time to treatment failure, it is time from starting of the medicine to the time of last administration. Time to next treatment or death, it is the time from index date until the start of the next systemic therapy or death in the absence of the next systemic therapy. So PFS was well maintained in all these real world studies, which we'll see one by one. So we can see the median PFS in Flora was around 19 months. Flower also gave us a PFS of 19 months. OCVAC gave us a PFS of 20.5 months. Spanish 25.9 months. Mykonos, again, the German subset, gave 16.2 months, and HOT 2002 study for elderly patients also gave us a PFS of 19.4 months. If you talk about the medium time to treatment discontinuation of flower, it was 25.3 months. In Mykonos, it was 17 and 19 months for USA and German subsets. For median time to treatment failure in OSIMEC study, it was 19.1 months. And medium time to next death or treatment discontinuation was in Mykonos was 17.9 versus for 15.9 versus 14.2 months for USA and German subsets. So PFS was well maintained in all these real world studies. So to start with the flower study, it is a first line osimertinib in the real world and inter-regional prospective study. It is a real world prospective observational study in which 9 Italian centers were taken with a total patient of 126, predominantly female, from June 2018 to September 2022, in which all advanced metastatic stage 3B and 4 EGFR positive non-small cell lung cancer patients were taken. The median age group was 68. Adenocarcinoma patients were 120 out of total 126 patients. 3 were squamous cell carcinoma. Only 12.7% of the patient had PS of 2 or more. Almost all of the patients were having PS of 0 to 1. Brain mets patients were around 30.2%, and patients with Charles Commodore Index 6 or more were 93.7%. So you can see EGFR positive patients 63% and EGFR 21.55%. Overall response, you can see partial response 73%, stable disease 23%, and progressive disease 4%. So median time to treatment discontinuation was 25.3 months. If you see the median time to treatment discontinuation in those patients with and without symptoms, then those patients without symptoms, the treatment time to discontinuation has not yet reached. And those patients with symptoms had 18.8 months. Again, those patients with metastatic sites up to 3 had median time to treatment discontinuation of 21.4 months. Median PFS 19 months. Median PFS in those patients with brain mets was 13.3 months. And in those patients, median PFS, CNS PFS in those patients at diagnosis was 15.5 months. So you can see it is almost same as what we got in Flora study. If you talk about the safety profile, it's fairly well tolerated drug. We know the common adverse events, diarrhea and rash. An important thing which we have to see here is around 8% of the patient had venous thromboembolism, grade 3, grade 4 events. So we all know that QT prolongation has also been reported as one of the rare side effects for osimertinib. In around 1% of the patient, we see that So that also is an important profile. So osimertinib confirmed its effectiveness and safety in real world data. Another study, OssiFact as first line in advanced metastatic EGFR positive non-small cell in real world setting, a retrospective multicenter cohort study of Japan with 538 patients from August 18 to December 19. First line metastatic advanced EGFR positive non-small cell lung cancer, median age 71 years. More than 75 years of age was present in around 37.7% of the patients. Majority were adenocarcinoma. Again, PS2 or more was seen in 16%, at baseline brain mets in 31%. The EGFR 1921 proportion almost similar, 49% and 45%. We can see the overall responses and disease control rate were quite high, 76.1% and 94.1%. The median PFS again was 20.5 months. Median time to treatment failure was 19.1 months. So PFS after first line osimertinib treatment was favorable. If we see the adverse events, the reason of discontinuation, mostly it's because of disease progression. Around 50% of the patients, another 25% of the patients had pneumonitis, and remaining around 60% had other events in the form of rash, diarrhea, QT prolongations, anorexias. And so mostly it's a well tolerable drug, apart from rarely pneumonitis and rash and diarrhea. Again, MyCon was a real-world study of patients of EGFR positive advanced non-small cell lung cancer treated with first-line osimertinib. This is a global observational cohort study from USA, Japan, Germany, and China from April 2018 to March 21. Again, first-line osimertinib advanced non-small cell EGFR positive. Median age was 17 here. In 35.2% of the patients were having age of 75 or more. Majority again adenocarcinoma, PS2 or more in 15% of the patient, and a diagnosis brain mets was seen in 33% of the patients. Charles comorbid index more than 3 was seen in 6% of the patients. So the result here also seen that at interim analysis, 58% remained on first line osimertinib therapy or were lost to follow. Another 18.8% received second line therapy in the form of either immunotherapy, ZK combinations, and other chemotherapies. Another 18.4% died while on first-line osimertinib, and another 4.7% discontinued first-line therapy. So here again, we can see the median follow-up time was 9.6 months, and median time to next distance is 17.9 months. So this interim results also support the effectiveness of osimertinib in real-world data. The finding for those German subset, again, in those patients also, the PFS was 16.2 months, and the time to treatment discontinuation is 19.2 months. So it also proves the effectiveness of osimertinib in real world. Another Spanish data, which was again a retrospective multi-center data, in which again 86% were taken, and the endpoint was PFS and OS. And you can see median PFS was 25.9 months, and the median OS was still not been achieved. What about the elderly populations? So another retrospective observational data from Japan, which took 132 patients with a median age of 80 years. Patients ranged from 75 to 90 years were taken. And again, first-line osimertinib was evaluated, this HOT 2002 study. In this study also, the median PFS was 19.4 months for elderly population, and median overall survival was not reached. So osimertinib is one of the most effective first-line therapy even for patients age 75 or more. What about the meta-analysis? If you talk about the meta-analysis, all the elderly populations in different study, which took into account as a Lux, Lung, Archer, and Flora-2, you can see around 40% of the patients in all these studies were elderly populations. That was with age 65 or more. And you can see the benefit with Flora study was maximum. So osimertinib provided the maximum benefit as compared to dacometinib and afatinib. This is clearly evident from the forest plot we can see. So this study also concluded that osimertinib has achieved a higher PFS than any other TGFR TKI, and it should be the preferred TKI even for elderly population. What about the CNS PFS? Again, the CNS PFS for Flora was also not reached as compared to 14 months in compared to TKI. Another data that was Flora China from China, which took 136 patients. Again, 24% were randomized, 24% in osimertinib arm, 32% in comparator had CNS mets at baseline. And incidence of CNS progression was lower in patients with osimertinib. We can see that ITT CNS PFS was 0.51, while PFS for those patients with CNS metastasis at baseline is 0.66. So even those patients with brain mets got benefited with osimertinib. So now the different PFS which we have got with various TKIs, first Jeftinib, which gave a PFS of around 8 to 10 months in Vijong and Pitong study. Erlotinib, it was 10 to 12 months. Then came Luslan 7. With Afatinib, we got 11 months. Then with Archer, with Dacometinib, we got 14.7 months. And the best we've got is with Osimertinib, that is 18.9 months. What about the benefit in CNS space? Yes, if you see the meta-analysis also, the benefit was quite clear. Overall response rate for CNS mets also, it was around 71%. Disease control rate was 93%. And the median PFS was also 12.21 months. And the NCCN also says the same. So we have now data for Flora 2 also. So they are saying even osimertinib combined with chemotherapy is the preferred regimen. But yes, for elderly population who cannot tolerate chemotherapy, definitely osimertinib is the standard treatment. So to summarize, real-world analysis studies help in evaluating efficacy of osimertinib in patients who are usually excluded from randomized control trial. Osimertinib has demonstrated benefit in real-world constant with the results seen in Flora. Current real-world studies show clinically meaningful efficacy of osimertinib among patients with elderly age group, brain mets, ethnicity, and specific mutations. And more emerging real-world evidence studies are anticipated, covering various population types, which in turn would give deeper insight about osimertinib potency in a large scale. Thank you. With this only, I will conclude, and if there is question, I'll be happy to answer. Thank you.
Okay, thank you so much, Dr. Ashish, to give
Thank
us talk. So for the next speaker, I would like to invite Dr. Ajay sir.
It is me only, Geetika. I'm sorry.
Yeah,
I
it's
was
okay,
just
sir.
busy with the session. So let me share my slides. And thank you, Dr. Ashish Upadhyay. It was a nice presentation from your side.
Thank you, sir. Thank you.
Sir, kindly share your screen, please.
Yeah, I'm doing that. Just a minute. Is it visible?
Yes, sir, make it full screen, please.
Yes, I will. Is it okay now?
Yes, sir.
So, very good evening to all of you. I think it was a wonderful presentation from all of the our speakers. So, most of the things they have covered, and I'll just brush up the things what they have said so far. So, my topic would cover few of the topics which Dr. Ashish has covered mostly. So, it would be a review of targeted therapy, the evidence based in the advanced metastatic EGFR non-small cell lung cancer. We all know that We all know that lung cancer is the one of the most common type of lung cancer. It is globally known as the second most common in males and third in the females. And India, it is the fourth leading cause of cancer related death in India also, and it is the fourth overall incidence. So the deaths, they are definitely, if it is the most common cancer, and the deaths would be also in the higher side only. And mostly it is in the stage 4 where we see the most of the deaths. And in stage 1 and 2, because we have lots of like treatment like surgery, radiation therapy, adjuvant chemotherapy. So here the rate of death has decreased. So, more than 50% of the stage 4 non-small cell lung cancer have biomarkers. We have predictive biomarkers and prognostic. Predictive are those where we see the therapeutic efficacy, and in the prognostic marker, these are indicative of the survival independent of the treatments. Oh, oh, my slides have gone probably.
No, sir, your slide is not visible.
Yes, yes, yes. Just a minute, just a minute. I'll share it again. Is it visible now?
No, sir, can you close the screen and again you will open?
Yeah. Is it okay? Not
Uh,
yet?
Not yet, sir. So tech support, can you please help it?
Sure. Hello.
Is it okay now?
Not yet, sir.
Then I
Just
think you have
share
to help me
entire
out.
So
screen.
can I share from my side? Is it
Yes, yes,
possible?
please. One of you can do that so that quickly we can do that. I don't know what has happened. It has gone from my desktop also.
Yeah, just 1 minute. I'll share.
So in the meantime, I think I'll continue with the my topic. So I was just saying that the deaths are more in the stage 4, and we have lots of biomarkers. Just take my phone, please, Pritam. Pritam.
Is it visible?
Yeah, it is visible to me. Yes. So let us go to the next slides. Next. Next. Yeah. So testing for the several genetic mutations and PD-L1 status is recommended for patients with NSCLC to determine whether they can receive these targeted agents or not. So we are doing ELK, EGFR, KRAS, HER2, BRAF, and PIK3CA, along with the MET, and sometimes we do NRAS and MEK1 also. Next slide. So these are the test methodology, which is already covered by one of our colleagues, like EGFR is done by the PCR, and ROS by checked by the FISH, and PDL1 by the ISC. Next. So EGFR driver mutations in lung cancer, mostly we see the mutation, they occur in the exon 19 and 21. Next. So, based on the limited number of study, the EGFR mutation appears similar across the disease stages, and the most, I think, prevalence is seen in the Asian population. It is 30 to 40%, and Caucasian it is 10 to 20%. So, stage-wise also we see Asians, they top the mutations. If EGFR TKIs were available in the resectable setting, a similar proportion may be able to benefit compared to the advanced settings. Next. So this is the NCCN recommendation. Here we can see that we can use the EGFR mutations in adjuvant setting also, and we can use in the locally advanced and small advanced metastatic settings also. Next. This is a diagram where we can see wild type and mutated EGFR activation. So if we see in the wild type, the EGFR activation mutations, there is a constant signaling by the EGFR. The pathway is activated always, whereas it is not so in the wild type category. Next. So the current treatment options for the advanced lung cancers are first line and second line. First line, we see which mutation it is, and accordingly we treat them. It can be the first generation, second generation, and third generation TKIs. And similarly, in the second line also, we treat with the chemotherapy or the TKIs, the next generation TKIs, depending upon the recommendations by the NCCN or the other guidelines which we take. Oh, osimertinib is the third generation. It is irreversible, CNS active, and it is active for both mutations and the EGFR T790 resistant mutations also.
पेशेंट पार्ट में है सर पेयर से होल्ड पे कर दिया ये भी रिपोर्ट
Cardiology consultation. So I said it is active in both the mutated and the resistant cases. We are talking of the osimertinib. Next. This is the FLORA study, which has been extensively talked about by Dr. Upadhyay. So in this, we have seen the role of osimertinib in advanced lung cancers. So osimertinib with the dose of 80, and it was studied against the standard of care EGFR. So we have seen the primary the PFS as well as the overall survival. Next slide. So the baseline characteristics were also balanced in both the arms. Next. So this is the median PFS. It was 18.9 months and 10.2 in the standard of care. So there was it was statistically significant. It was in the favor of the osimertinib arm. And there was a death reduction of 54% compared to the standard EGFR TKIs. Next. The forest plots again is showing that there is a benefit of osimertinib over standard EGFR TKI with respect to the PFS as shown across all the predefined subgroups, whether it was age, smoking, race, or CNS metastasis. Next. So efficacy, that is ORR, the duration of response was twice as long in patient treated with osimertinib compared to the standard EGFR TKIs. Next slide. Coming to the overall survival, the final analysis of OS demonstrated again a meaningful and statistically significant improvement with the osimertinib. It was 38.6 months, and in the EGFR TKI comparator, it was 31.8 months. So it was significant in osimertinib arm. Next. The adverse event summary, it was not bad. So adverse events you will see, they were comparable in both the arms. Like we see diarrhea, rash, nail effects, dry skin, stomatitis, but they were well tolerated. So the percentage was not that high. Next. Again, the overview of adverse events, if we see in the osimertinib arm as compared to the standard of care, they are less in the osimertinib arm as compared to the SOC. Even the grades were lesser in the osimertinib, the grade of the adverse events. Next. So to summarize, osimertinib is a significant and clinically meaningful improvement in PFS, and not only PFS, it has a meaningful improvement in CNS PFS over the standard of care. And the final analysis of OS results showed promising survival trend favoring the osimertinib, and it is a new standard of care. for the first-line therapy in patients with mutated EGFR in advanced NSCLC. And the safety profile was also definitely better as compared to the standard of care. Next. The important thing about osimertinib is its CNS efficacy. Uh, it has higher rates of penetration in EGFR mutation compared with the wild type EGFR. So if we see the frequency of CNS metastasis, it is more in brain mets are more in the mutations rather than in the wild type population. And again, leptomeningeal metastasis is more in the EGFR mutated as compared to the wild type EGFR. Next. So osimertinib benefit was consistent in patients with and without CNS metastasis both, and the CNS progression was also few, as it was observed in the osimertinib, it was 6%, and in the standard EGFR TKI, it was 15%, the CNS progressions. Next slide. So again, the same thing, we have seen that PFS in CNS full analysis set. So osimertinib was definitely better as compared to the standard of care, as far as the CNS activities is concerned. Next slide. Now coming to the comparisons with the other TKIs like decomitinib or afatinib, we have various trials for all these. Like if we say osimertinib and decomitinib, we have Archer trial where dacometinib was compared with gefitinib, and Flora trial we have already discussed osimertinib with this comparator of other EGFR TKIs. So if we see in the Flora trial, there is an immediate separation. It was already discussed by me and Upadhyay also said. So definitely it has more meaningful like PFS and OS as compared with the Archer of dacometinib. Next. So the OS was not statistically significant since the comparison of ORR was not statistically significant based on the study's hierarchical testing rules in the ARCA trial. And in the Flora, first time an EGFR TK has translated the PFS to the significant OS benefit. We have already discussed the months of the benefits in PFS, and in the OS also it was 30.8 months. Next, 38, sorry. Next. So the p-value was not reached with the dacometinib in the Archer 1050, and we could not get the OS survival. Next. The another EGFR TK is the afatinib, the Lux Lung 7 trial, where PFS was studied with afatinib, and the afatinib had a median PFS of 11 months, and osimertinib has a median PFS of 18.9 months, and there was insufficient events to determine OS of afatinib at the time of analysis. So again, osimertinib had a superiority over afatinib. Next. Again, the Lux Lung 7 trial, which is showing the overall survival advantage, it was not seen. It was 27.9 versus 24.5 months. So the hazard ratio was 0.86 and the log rank P was 0.2. Next. It is pre-specified specified subgroups in exon 19 deletion and L85 L85R8R, and the similar OS trends were seen in these studies also. Next. So comparing the safety profile, the Flora study in which the osimertinib was used, Lux Lung 7 afatinib and Archer dacometinib. If we see the adverse events like skin rash, paronychia, diarrhea, so we can see that Flora study, that is drug osimertinib, was well tolerated with very few side effects. And the afatinib and dacometinib, they have shown some side effects with the percentage ranging from 2 to 66%. Next. So, Flora study has not only like significantly told that it is a first line treatment, and It cannot be used in the second line or the third line setting. So it has also done the sequencing study also. And it was definitely resolved by Flora study that it can be used at the second line or the third line, this sequencing also. Next. So if we see the second line treatment eligible, all if we say is or all the patients eligible for the second line, and what is the prediction for T790 mutations? So if we see 10 patients, out of these 7 patients they receive the second line therapy, whereas 30% patients they do not have an opportunity to receive the second line therapy. So next slide, it is not possible to predict who will develop the T790 resistance. So if we see in this slide again, this color, purple color is showing that the percentage of people who have received the second line therapy. So, and out of this 65%, only 47% have received the second line therapy with the osimertinib. Next. And this graph is showing that 47% patients who have received at the second line, still the real world evidence show that 1/3 of patients or fewer, they have received the second line osimertinib. Next. The guidelines have shown that if there is a EGFR exon 19 deletions, preferred first line is osimertinib, whereas we can use it in the other sequence also. We can use osimertinib with the chemotherapy like pemetrexed, and we can use it in the second and third line settings also. But the preferred recommendation is the first line treatment. Next. So to conclude, for the first time in the evolution of EGFR TKI, osimertinib have translated the PFS to the OS benefit. The osimertinib has a median PFS of 18.9 months and OS of 38.6 months, which is higher than the first and second generation EGFR TKIs. And not to forget its efficacy in the CNS metastasis. And there is a few CNS progressions, like in osimertinib, it was 6%, and in standard of care, it was 15%. There are less side effects in the osimertinib with a better safety profile. And osimertinib is the new standard of care, and it is the first line therapy in the metastatic EGFR advanced NSCLC. Pritam. So with this, I conclude my topic here. And with this, Geetika, if you allow me, can I do the concluding remarks now?
Okay, thank you so much, Dr. Rajesh sir, for the wonderful talk, and thank you all the speakers to join for today's session. Dr. Rajay, is it any closing remarks here?
Yeah, closing remarks my side would be I thanks to all my colleagues over there who have found a time out of their busy schedules to come over this webinar, and it was definitely like I'll say definitely it was a great learning for all of us, and see you in some time in some other webinar also. So thanks again from core of my heart. Thank you and have a great day.
Okay, thank you so much and good night, sir. So thank you, tech support, to join
Thank you.
to conduct this webinar. Thank you, Ashish sir, for the support. Thank you much. Good night, everyone.
Thank you.
Thank you, Ajay sir, for
Thank you,
including
sir.
me.
Thank you, Ajay, sir.
So tech support, can you close the meeting now? So tech support, Uday, are you there?